very good afternoon to everyone who is present here. We have come up with a new session, and this is the second time we have brought this session. The first time, unfortunately, all of us had to meet virtually because of COVID. But even then, we had a wonderful session last year. A lot of our mentors are coming again, and we really thank all of you. So the main essence of this is when a young ophthalmologist is ready to take up sub challenges. So all of us have been in that situation where we have learned from our mentors, we have seen how they do their challenging cases, their difficult cases. But when we go into our own practice and when we need to face these challenges ourselves, we often have to make these decisions. And once we've done it, we want to discuss and we want to find out if we could have done anything more. So we are going to have a number of very interesting cases from our young ophthalmologists, and we'll be coming to them one by one. And I'm going to be supported by one of the most dynamic ophthalmologists we have today, that is Dr. Aditi. So over to you, Aditi.
Thank you so much, Sneha. So, without further delay, we'll just start our session. So, may I now request Dr. Nilutparna Deori to join us to present the cataract case. She does not need an introduction. Ma'am is Associate Consultant in Department of Strabismus, Pediatric Ophthalmology at Sri Shankara Deva Netralaya, Guwahati, Assam. Ma'am is an active member, International Coordinator of MSICS Society. So, over to you, ma'am.
Thank you so much, Dr. Aditi, and thank you, Dr. Neha, for this invite. Honorable members of the panels, today I'm going to present a case of pediatric traumatic cataract. How to do the case when you have... Oh, okay, sorry. So the purpose of actually presenting this case is, especially during the COVID times when most of the cases were treated in the periphery, some of the penetrating injury cases had to be empirically treated or managed medically, and then they turned up with adherent leukoma, phimotic people, and it was difficult to manage those cases surgically. So considering this as a challenge for those young ophthalmologists who have come up, so I wanted to present. So can I go ahead now? Yeah. Yes, thank you. I do not have any financial disclosure for this presentation. So as you all know, traumatic cataracts do compromise the visual outcome owing to the damage that they has already caused to even the other ocular tissues. These are some of the morphological characteristics of traumatic cataract that I have presented. The first one is a rather straightforward rosette. The other one with penetrating injury of the cornea with some injury of the iris tissue. But the last one is the one that presents a challenge, because in children you have to consider the amblyopic condition of the child post surgery and also the implantation of the IOL, whether you will be able to implant the IOL in the same sitting or would you like to go ahead in the second as a secondary implantation. So for example, this is an 8-year-old girl who suffered an injury to the right eye 6 years back, and the visual acuity had dropped down to only PL. Even the perception of rays was also, projection of rays could not be interpreted properly. And you can see the adherent leukoma exactly just in the visual axis, just a little up of the visual axis, and the pupil, you see how it has been dragged towards the adherent leukoma and it has become a slit-shaped pupil. So in these situations, you need to go ahead with a VEP. You can also go ahead with your UBM or an AIOC to see the structures or the lens behind. Gonioscopy, however, did not reveal any recession or broad base past in this child. There is an exotropia because of the amblyopia that has set in. So a planning of pupilloplasty membranectomy was done, and we thought that we'll go ahead with an IOL implantation and anterior vitrectomy in the same sitting. Now, since we were going ahead with this procedure, we took into account what the condition of the endothelium was, because in these cases it is better to avoid the ultrasonic power for the patients, because you see the CV ratio is very low, around 28. Now, the ultrasound, in the ultrasound of the eye, you can also take hint about the cataract. Now, membranous cataract is another form of traumatic cataract, which presents as a challenge. In this situation, you can see the, I'll put on the arrow. The arrow that, this spike that should have represented your lens is absolutely going down. Now, in these situations, you do not have the lens thickness, you do not have the PC morphology, so it becomes difficult to assess. So we have to be ready in these situations that if you are planning for an IOL, then if the IOL is a 3-piece IOL and then vitrectomy system. So for youngsters, vitrectomy, anterior vitrectomy or learning the vitrectomy system is essential to go ahead. Now I have done an anterior limbal route. I have made a 3-port so that I don't need to make more nicks later on. So under the OVD coverage, cohesive OVD, I have done a stretching of the pupil so that at least I have some view of the cataract behind. Now you see the stretching I have done not in the same meridian as the adherent glaucoma, but opposite to it. After a little bit of viscodilatation, I went ahead with the cutter. Now when I'm using the cutter, I'm bound to cut this fibrovascular tissue and the redundant tissue. So there is a bleeding in these situations. Now you feel the adhesion as you go ahead, and then you plan the cutter or the scissors, micro scissors that you would like to use. Now when you are cutting this fibrovascular tissue that is adherent to the cornea, you need to have the endocautery in your armamentarium when there is a bleed. So now I feel that the superior end is almost released. So I will go ahead with the scissors, micro scissors, to release the terminal end. So you see, it is already released now. Now when I'm cutting the redundant tissue and forming the pupillary margins, you see there is a bleed. So use the endocautery as and when required so that you get a good feel. I have put in adrenaline because the inferior end of the pupil had maintained the sphincter and the dilator muscles. So I went ahead with a peripheral rhexis with the microcapsular forceps. Superiorly it was difficult. I finished it as a hemirhexis and then I completed with a vitrectorhexis. Vitrectorhexis and continuous curvilinear rhexis has got its strength and its drawbacks. And with the same cutter, I went with the aspiration. Now the advantage for me here was that I had already made 2 ports before. So while maintaining the AC, I went ahead to complete my case. Now, since I knew that I had the peripheral rim, that is the tire-shaped rim of the bag, so I went ahead with the IOL implantation in the bag. Now, I made the wound a little larger so that it is easy for me to maneuver the 3-piece IOL into the bag. Sutured it up with 10 of acryl, and now I have planned for the PC to address the PC. So when you are using the cutter, you have to place the mouth of the cutter, that is the opening of the cutter, down and not move it too fast because this vitreous is liquefied and you need to be very careful about this vitreous. I only excise the last strand of the fibrous membrane because if you pull too much in the beginning, then you are going to cause tension in the bag and you might end up with more complications later on. So before the last wound suturing, I have placed air bubble, and that's how I finished the case. So this is the post-operative results of the child, and she has counting finger 1 meter. The CV at that time was 28, now it has gone down to 22. However, it has maintained its hexagonality, and the fundus picture is quite, we feel happy with the child having regained his vision, and we would go ahead with the rehabilitation of the child. Now, proper planning is important in these cases. That is the message that I wanted to give from this challenging case, because you have done a good cataract surgery in traumatic cataract, especially in membranous type. But you see the yellow arrow that I have pointed is that if you have not released the adhesion, then you end up with occlusion of the visual axis, the primary visual axis, and the brilliant surgery that you have done does not actually serve any purpose. So the photos on the top are some of the situations where you can end up with extremely difficult, more difficult cases. But the message is only proper planning before going ahead with the surgery, because it's not the skill of the surgery, but the planning of the surgery that I believe in. Thank you so much for your kind hearing.
Thank you so much, Nilutpana ma'am, for that excellent case. May I now request our panelist for the session, for the cataract session, Dr. Nagendra Prasad sir. He is a senior consultant anterior segment and cataract, trained from AIMS and has been working since more than 27 years. Sir, please, would you like to comment on the case?
Actually, very excellent presentation, and you did proper planning and management very well. I would have been in the same planning. The only thing concerned about how to obtain the keratometric value, and in these cases, is it did you take the keratometry from the other eye, or you just
I take the keratometry from the other eye, but axial length and everything I measured
from the
from
same eye?
same.
Excellent.
So that definitely is a factor that happened in this case. But the post-operative refractive estimate that estimated that I ended up in this patient was
Yes.
-4. So
Yeah.
we'll have to tackle that probably. But right now the main concern was the visual axis to be cleared and the amblyopia to be
To be taken care of. Very good.
maybe
Very
in the
good.
second
Yeah.
time. We'll plan because in the same sitting I cannot plan the entire.
So far as the scar tissue is technique removal in these cases, that it is very tough tissue.
Yes.
It doesn't come out with the single-handed. If you're going to manage it, you have to pull from one hand and then cut it.
Yes, sir.
The cutter does not work very well
No,
in those cases,
it
and
just keeps on slipping because these are guliton shaped cutters.
yeah.
So it just slips between the gulitons. So
And depending upon the location of the opacity, you have to plan your incision
yes,
into
sir.
the eye, so it does not come directly behind your,
Yes.
and you have to have a staining of the capsule, because you may be going under the opacity area. So, and use always forceps. In my opinion, it is always better to have a forceps, micro forceps too, because if you go inside the opacity area, you can pull through and always into the visible area. Very good, excellent management and all. Thank you. Nothing to add.
yeah, actually there has been a debate regarding this many times. Even I was also told many times that why are you not using Vicryl? So I spoke to my mentors also in SN and Jalal ma'am actually she says that you should be. I looked at the literature also and I participated in some of the online that we given who is using what surveys. And I started using now 10 or Vicryl, but a little older. Like she's 8 years old. Yeah, she's 8 years old. But in younger patients where I am routinely doing pediatric cataract surgery like 1 year or 2 year, I am a little hesitant. I am using nylon because astigmatically the things are okay, but if we have those deposits in loose sutures, it is very difficult to cut because Vicryl, if you go and cut 10 to 10 of Vicryl, it doesn't come out, it just breaks. So I feel that suture itself is a cause for your endophthalmitis. Rather, it's prone for infection. So I would like to also. Yeah, so I would like to avoid Vicryl as of now. So this is just my initial experience with Vicryl. So I would not say that it is my theory, but just a hypothesis that I'm working on.
Just a little bit, since you have used three-piece aisle,
I used a three-piece.
three-piece aisle, so you can always have a option to capture behind the eye.
Yes, yes.
That is
Exactly
because it is
my
very
idea.
tough tissue, so you could have so making it more physiological
Yeah.
and
I
cornea
because my
friendly to
bag
the.
was already there, so
Yeah.
it was already in the bag. I placed it in a way that it doesn't come in the opacity.
Yes, ma'am.
Why not pars plana vitrectomy?
Yeah, I can go ahead with pars plana vitrectomy, but children who have suffered this kind of trauma, the other ocular tissues are also damaged. And as a personal thing, I am more comfortable with the anterior limbal route. And the vitreous control has come to me only when I am using a low vacuum and a high cut rate. And what I'm doing is I'm making it matka shaped vitrectomy, core vitrectomy, so that I'm going under the. I make a small
Right.
rent, and then I go behind. I stay there till I know that I don't have.
How much deep you have to go?
Vitreous, yeah. And once I know that I have cleaned off behind the posterior capsule, then only I go and cut the
Cut
posterior
the
capsule.
tissue.
But in normal cases, I go with a PPC with the micro
Okay, no problem. It depends upon surgeon preference only.
I prefer to go ahead with the vitrectomy first and then do the CCC. But there are different cutters also coming up 25 days and all. But since the wounds are large and the sutures, the gap is more, I do not want the AC to collapse. So I'm
Collapse.
using a 23 only. So that I don't have too much of egress of fluid and then the vitreous. What I look for in normal TC is that the flap, movement of the flap. Once the movement of the flap is more, I know that the vitreous is going to come. So be careful and complete your vitrectomy and then only come out. So that is what I feel myself.
Do you think that in spite of cutting the pupilotomy,
Yes.
pupil expanders would have helped?
Yeah, pupil expanders might have helped, but here I did not need pupil expanders. Once I released adhesion, the pupil expanded on its own with adhesion. So that much of pupil dilatation was enough for me to.
And that is
Right.
that is
So,
enough. Nothing to.
if I could just interrupt, we have 4 more speakers and we
Okay,
have
okay,
only
thank
1 hour. So, we would definitely want to take this up at the end. It was a really interesting case. Thank you so much, ma'am. So, from cataract, we move on to another subspecialty, that is glaucoma. And we have Dr. Prasanna Venkatesh Ramesh. I'm not going to introduce him too much apart from saying that he is also interested in artificial intelligence, 3D printing, and academic filmmaking. So, Dr. Prasanna, what is the challenge that you are taking up today?
Today is all about surgery, so we are going to learn. Can I have my slides? Yeah. Can I have my slides? So today is about challenges from learner's basket. So I thought we'll have something which is very basic, so that we'll all how did I learn, and how are we all it's coming here. Okay, my slides are there. Can I have it there? Yeah. So it's flapping your trabeculectomy surgical wings. I'll be just quick. I'll take 6 baskets, each 30 seconds. We'll have basket 1. Taking the flap in the area of perforator. Never do this. When you see a perforator like this, never take the flap in the perforator. What happens if you take the flaps in the perforator? You see, I made this mistake. There is a perforator here. When I took the flap, see that it just comes, it keeps on bleeding. It's very difficult for you to proceed further. In that case, just take your cautery and just have a small touch with the cautery, and that's it. It's over. But then again, there is another perforator. As I keep dissecting and keep going on, I'm forwarding the video for want of time. I'll finish it quickly as promised to Sneha. And as I keep going there, again here, there is another perforator. So again, I'll have to keep going and do the same. See, I mop it and there is a perforator. So lesson 1, basket 1, never take your flap in the perforator. So this is all about case 1, or else you'll have a tough time ahead. Basket 2, bleeding from the surgical PA. Sometimes when we do a trabeculectomy, there is always a chance that once you complete your ostium punch, and when you do your PA, you see I've done a PA, and suddenly there it starts a pulsatile ooze from the pillars of the PA and bleeding. Never do this. You saw me doing initial days I used to put saline, then what my mentor told is just use your flap, put a mechanical tamponade on it, and automatically things will settle through. So this is the second thing that I wanted to show you. Now see, it will be very tempting for you to put a saline because you can see the pulsatile nature of the bleed, but just put the flap and it'll automatically give you an area of tamponade and things will slowly settle in. Even if there is ifema, don't panic, it'll all settle down. So take 3 or the basket 3, trabeculectomy flap taken during AC collapse. See, in the initial days we used to use a traction suture. This was done by my fellow actually. I gave him to put the traction suture. It was a full thickness one. You can see the chamber has actually collapsed. Especially when we are going with only trabeculectomy, we don't have the option to enter into the AC and put visco. So you can see the flap, I don't have any counter traction force to actually take the flap. So without any counter traction force, slow and steady maneuver movements, and the flap is actually being taken. So you can see that the AC is almost fully collapsed, but the flap can be taken. Just follow the basics. Don't need to panic. Just keep the basics oriented. Hold your apex and take the flap in a very slow and steady manner. You have all the time in the world. Our idea is to give the best possible outcome, not the time of surgery. Take all the time in the world, and it can be done. There is no need to panic. So that was my 3rd basket that I wanted to show. And I'm ending that basket by showing, see how difficult even I found my paracentesis to do, because I didn't want to puncture the anterior lens capsule. So we'll go to basket 4, improper AC entry. Again, this is very, very important. A good flap will be taken. Sometimes when we are entering into it, a slight defocus of the surgical microscope and upward tilting of your blade. I just showed this. A mild upward tilting can cause a slight buttonhole, but you will have to recognize it on the table so that you don't handle with any buttonholing. So I was able to do that in this case, and you just need to change your side. Take 5, aligning your flaps. I'll just finish in a 10 more seconds. So in this flap, what happened was, you can see that when taking the flap, this area, the flap slightly, the curve changed at this point. So that what happens is, when you do a flap of this and when you try to do a single suture, you can see that the geometry doesn't align. So in these kind of scenarios, when you have a slightly curved flap like this in your initial days, never try to suture it with a single flap. The geometry will not align. Use three sutures, one here, one for this curve and one for this. And the last one is, this is the base moving. This was one of my recently operated cases. I found there is something troublesome when I was trying to do this case. It was a block patient under subtenons, but something was not right in this patient. I was just not feeling comfortable. Once I finished my trabeculectomy and my cataract surgery, I just saw this patient that there was a mild seesaw movement that I'm just showing. You can see the eye was just moving in a seesaw movement up and down, and we get all kind of possibilities when we operate. So these are my 6 baskets. I just wanted it to be as basic as possible. I hope it will be a good learning for all. And our idea is to move from here to here, where we'll have a good flap. Thank you. That's all about. And I would like to acknowledge my mentor, Dr. Satyan Parthasarathi, who has been taught everything to me in glaucoma. Thank you, sir.
Thank you so much for that excellent talk, Dr. Prasanna. So we will take some tips from none other than Dr. Rastogi, who is the General Secretary, HOS, and one of our favorite teachers. Sir, over to you.
Yes, sir.
So, which you will prefer in trap?
Sir, I would prefer a corneal suture. For myself, it works better for me in my hands, and that's what
Basic teaching is bridal suture. Why not we are using bridal suture? Earlier it was a bridal suture teaching. Why we are not using?
So for me, sometimes we tend to have some, we do some topical trabeculectomy as well, sir. In our center, there is a culture where sometimes we end up doing a topical trabeculectomy as well. So at those times, this works.
Everybody is not perfect in topical.
Yes, I do agree. But as per your comment, bridal suture also can be followed. Yes, sir, I do agree with you, sir.
And you have say not one suture, 3 suture.
Yes,
so why not releasable sutures?
Sir, that particular instance, sir, releasable suture, I do agree, sir. That is also very much true. For that instant, we give steps to our fellows, sir. So at that step, what happened was, he came like this and then he went slightly like this. For that patient, a single suture did not give the geometry of closure. The AC was just not forming. So we had to release the apex there. I never put an apex suture there. It was about 3 sutures, which was a non-apex suture. Some instances where we needed to slightly go up, sir.
And in case of, you said perforators,
yes,
so how do you change the site?
Sir, in case of maybe 1 or 2 perforators, maybe we can, if we are able to manage, then well and truly yes. If it's not been able to, or if it's very novice surgeon, then better to avoid, sir, actually in the first place, rather than.
That's right.
Yes, sir.
Better to avoid. But if you are accidentally met with this perforator,
sir, I'll try to use one burst of cautery. If I'm not able to get that, then I'll definitely contemplate doing that also, because I don't want to do over cautery and then cause a flap bed which is going in for thermal destruction.
Yeah, and another thing, that bleeding, you're reposing the flap to stop the bleeding.
Yes, sir.
So, suppose the surgeon is anxious,
yes,
he is not experienced like this.
Yes,
He is
sir.
trying to washing. How much time it will take and what will happen?
Sir, it just keeps coming. I have just encountered it only once or twice. In my so far the surgeries that I have done.
Yeah, usually it stops.
The only point is, I remember my mentor telling me during my training that never do this. But I also ended up doing that only in the first place. Since it's an edited video, the same unedited video, for 5 minutes I was doing that. Then it came to my mind that he told me, right, why are you doing the same mistake? Then on the table I had to reassess. The same patient had mild ifema. It was 2 mm. We waited for 3 to 4 days and it came down. Maybe there is a chance that the ifema may not even come down also. But as of now, I have not encountered that in my practice so far, sir.
Sure.
Maybe you can throw your
Thank
views
you.
on it.
Thank you.
Yeah.
Nice tips.
Thank you, sir. I just wanted it to be a amalgamation of 5 to 6 snippets rather than a single
Yeah,
case.
definitely.
So that for the benefit
they,
of the...
They give you overall...
Yes, sir. More regarding the flaps in trap. Thank you.
not one case, but they give you...
Yes, sir. Yes, sir. It's more... sir, I have no experience on rectangular flaps, sir. I started my training with triangular and I'm still going with triangular, sir. Currently, sir, I have no experience in other than a triangular flap, sir.
We used to do only triangular flap most of the time, unless you combine with the FECO, so you can go with that square one. Nothing.
Thank you so much for those expert comments, sir. And from glaucoma, we now move on to refractive surgery. Dr. Aarti Agrawal is also one who has done her fellowship in advanced cataract and refractive surgery from Narayan Nethralaya, Bangalore. And she has a very, very interesting title. Let us see what is the challenge that she has to present.
Hello everyone, very good afternoon, and at the outset I would like to thank Dr. Partha Biswas sir, Dr. Sneha, Dr. Aditi and all the expert panelists for letting me talk over here. So as the topic says, it ain't over till the fat lady sings. So usually whenever we get a case of traumatic LASIK flap dislocation, there's a worry in our head, we little hesitate, give guarded prognosis and we don't know what the outcome would be. But with proper management, you can give 6/6 to the patient if handle the case properly. So I am presenting 2 cases. This is my first initial case which I did of traumatic LASIK flap dislocation. So this was a patient who presented immediately after the trauma, or I think within 24 hours. She had a injury with a tree bark injury. So this is my first case which I ever did in my life of flap, repositioning. So there are a couple of mistakes which I made, which I am going to talk later. First of all, never lift the flap in the first go, because the whole idea is that whenever these flap folds are there, the epithelium is very tightly adhered to the Bowman's. So even if you're trying to iron out the flap, it will not happen. So the whole idea is that you need to remove the epithelium in order to release these folds. And if at the first go, if you lift the LASIK flap, it becomes really difficult for you to remove the epithelium. So first in this case, I tried doing it just after lifting, tried to doing with Merusil sponge, but it didn't work. So then I went ahead and started to debride the epithelium. Here I'm using a hockey stick. You can use any spatula, you can use a 15 number blade, as per your convenience. So when we kind of release, whenever we remove the epithelium, that's when the Bowman's is, slightly more, you can slightly maneuver it better and you can release these folds. So first what I did was I initially just removed the central epithelium, tried to iron out the flap folds, which happened pretty well. But then there were some folds in the periphery which I didn't want it to leave. So I went ahead and started removing the epithelium as a whole. One thing, if you can notice, I have removed the epithelium from the edge margins also. This is one of the most important steps because you don't want any ingrowth to happen in the LASIK flap. So whenever you are doing this kind of a case, one thing is you debride the epithelium from the edge also, so that your flap adheres by the time the epithelium is growing, and so you will not end up in any ingrowth. This is the second case. So before I start this case, the first mistake which I did, like I said, that I lifted the flap immediately. That should not be done. Second thing which I learned is to dilate the patient before taking in the OR, because this helps me visualize the folds better. Third thing which I didn't do was I did not do any marking. In this case, I have dilated the patient, so the flap folds are more easily visible. I have done a corneal marking which is not very clearly visible. It's at 8 o'clock. The same thing, I debride the epithelium before lifting the flap, release the folds with the help of Merusil sponge, and then went ahead to lift the flap and, clear the interface, make the flap bed even more smoother. So this was a superior hinge. This was again a case of, it was a blunt injury presented to me after 8 days of the trauma. This is a superior hinge. I lifted it, cleared out the folds from back, and then the case is done. So just a couple of things which I would want to mention. Like I said, always better to dilate the patient because that helps you, visualize the folds better. Then the second thing, mark, so that whenever you're repositioning the flap, you're repositioning it at the anatomical position. The third thing, what I also learned was that you have to debride the epithelium so that in order to make the flap folds go away easily, smoothly. And the fourth thing is, when I place the contact lens, BCL, don't be in a hurry to remove the band-aid contact lens. At least place it for 1 week before you remove it, because that will help it kind of gives them a tamponade effect. Thank you. Thank you.
To discuss this case, we have Dr. Dhaval Haria from I&I Hospital and IVF Center, Mumbai.
Hi Aarti, you managed it very well. I just wanted to ask, the second case was how many weeks or months post LASIK?
So that was done 5 years before. The patient had undergone an elbow injury. And since it was, if you must have seen, it was not in the center. So the patient didn't notice. The patient thought that maybe because of injury, I'm not seeing clearly. So the patient presented on the 8th day of injury.
Okay, but it was 5 years post LASIK.
5 years, yeah. And the first case was 11 years.
Okay, it was 11 years.
So MK flap, that's actually one of the major differences between an MK flap and a femto flap. MK flap, even after years together, it can get dislodged very easily. Although that can also happen in femto flaps, but of course the chances are less. So that's why we are moving to an era of surface ablation and trans PRK, where there are no flaps and then no chances of any complication, even immediately or post surgery.
Yeah. Just a little question.
If given an option, I would. If I am to operate on any of my relative, I would only opt for trans PRK because, a flap, a cut is a cut. Now or even 10-15 years later, a cut will always be a cut. So there is a chance that, you may end up in this kind of problem anytime after any kind of cut.
Just one little question.
So now ever since I've started doing trans PRK and I've seen the results, almost 60% of my practice is shifted to trans PRK rather than a flap-based procedure. I have corrected as high as -10 also with trans PRK. It's the ablation microns which is important rather than the refractive power.
Any corneal haze?
I have not seen any.
Just one question I want to ask. Just how the folds goes next day immediately, or it takes some time to?
No. Sir, the fold has to go on table only.
Okay.
If you can see a fold on table, you will see the next day also.
No,
So when you are ironing out, that's the reason that you remove the epithelium. Be very don't hesitate to remove. I have removed the entire epithelium also end to end, and they do really well.
No.
Until unless you remove the epithelium,
It
your
is not
folds
going
will
to settle.
And if you are seeing a fold on table, you will see it next day also. So you have
Any
to
idea
remove
of putting
everything.
suture in for the tightening, suturing?
In my practice, I have not. I have had I have done 6 or 7 only.
Okay.
But they do very well. Just place the band-aid contact lens, keep it for 7 days. Don't be in a hurry to remove it. They do really well.
Good.
But have you come across in your practice?
So we would like to have the presentation. We'll take the questions later if we get time, please. So may I now request our star retina surgeon from West Bengal, North Bengal, Dr. Deepak Agarwal. He has been awarded multiple awards, multiple publications. He was working in Disha Eye Hospital. He's been trained in Vitreretina services. Right now he is working in North Bengal, Siliguri Greater Alliance Eye Hospital. Over to you, Dr. Deepak.
Thanks a lot for such kind words. So, my case is a case of subretinal hematoma with inferior RD, which was managed with subretinal tissue plasminogen activator and an inferior 180-degree retinectomy. So, I have no financial interest in any of the products mentioned in the case. So case history, a 55-year-old female presented to us with severe diminution of vision in the right eye for 15 days. At presentation, her vision in the right eye was hand movement and the left eye was 6/6. Anterior segment was essentially normal except for a very early cataract. So what we see in the fundus photo is in the right eye there is a massive subretinal hematoma which is extending both above and below the arcades. Left eye is essentially appears to be normal with some amount of disc pallor in the temporal region. So let's look at the OCT. The OCT shows us what I am trying to see is subretinal hematoma, which is indicated by the yellow arrow. There is a subretinal fluid, as well as there is subretinal heme, sub-RP heme, sorry. So let's look at the case. Let me just say in the beginning that after the case presented, the patient presented for OT after 10 days. So pars plana ports were made. Now when I entered the vitreous cavity, I was surprised to see breakthrough bleeding, which was removed with core vitrectomy, followed by PVD induction, and then the completion of vitrectomy. Now I am injecting subretinal TPA with a 38 gauge subretinal needle at multiple sites. After these injections, we waited for 10 minutes for TPA to act and the clot to dissolve. A 180 degree, in the inferior part of the retina, 180 degree cautery was performed, endocautery was performed, followed by 180 degree retinectomy with cutter. The entire subretinal hematoma was drained out by the suction property of the cutter. The inferior detached retina was folded upon itself to look for the submacular pathology. And the blood which was present in the submacular part was removed with the suction property of the cutter. The detached retina was placed back with PFCL, and some endolaser was performed at the margin of the retina. Fluid gas exchange was performed. And also the removal of PFCL was done. Endolaser was completed with 360 degree endolaser was completed. And silicone oil was injected. This silicone was of 5,000 centistrokes. In the post-operative period, at 14 days post-operative visit, the vision has improved to 6/60 from hand movement. And what we see is that in the pre-operative period, the hemorrhage subretinal hematoma has gone, and even the sub-RP hematoma is resolving. Thank you very much.
Thank you so much, Dr. Deepak. May I now request Dr. Manoj Saswade, sir, to comment. Sir is trained from Shankar Netralaya, Chennai, and is presently founder and director of Saswade Eye Clinic and Laser Retina Clinic at Aurangabad. Sir, over to you.
Yeah, well done, Deepak.
Thank you, sir.
Let me know why you do the subretinal surgery.
Pardon, sir.
Why you opted for going for the subretinal surgery?
So in this case, the hemorrhage was very thick. It was long, 15 days has passed from the presentation. And also it was a massive subretinal hematoma. So it, without subretinal surgery, it won't have helped much to the patient.
Was it a predominant subretinal or a sub-RP hematoma?
Pardon, sir?
Was it a subretinal or a sub-RP hematoma?
It was both, sir.
You just see your OCT.
Yes, sir.
The amounts are from sub-RP.
Sub-RP as well as subretinal.
And there was a breakthrough, and
Yes.
it was a old vitreous hemorrhage. Why I am saying that? What is the importance of timing in such surgeries? Is there any importance of timing in such surgeries?
So I was actually surprised because when the patient presented to us, there was no vitreous hemorrhage, but on OT table there was breakthrough vitreous hemorrhage.
But on this was a old vitreous hemorrhage. It was not a fresh red color hemorrhage. You can see that that was a khaki color vitreous hemorrhage. That means itself suggests that it was a long standing.
Oh, sir. So it's
Yeah, that's the thing. And second thing that why timing is important. The answer is that
because the toxic effect of the
toxic
blood,
effect. Toxic effect of what?
The heme which is present in the
Heme, when the RBCs lies, it converts into heme and bile component. The bile is more toxic. So we want to do, and that timing is important. Already 15 days were over. And second thing, the hemorrhage it itself was altered. So in cases why you did not tried the anti-VEGF in this case? What was the basic diagnosis in case?
So most likely it was PCV. So
Yes, PCV will be managed with anti-VEGFs or directly a surgery is a indication.
yes, so that can also be tried.
Yeah, that's the thing is that in nowadays we don't require a 180 degree inferior retinectomy in the presence of or availability of anti-VEGFs, in the availability of TPS, availability of SF6 gas, all this can be tried first.
Yes.
Otherwise, this surgery itself is more traumatic. This is a massive hemorrhage, subretinal as well as sub-RPA, and the surgical trauma is more than the. It would have been managed well without that, and you get the equally good results with this.
That can be tried in the future.
Yes, yes. Thank you very much.
Thank you, sir.
Thank you so much, sir.
Thank you, sir. So now from retina, we move on to oculoplasty. We have Dr. Rituja Thomas Grover, who has completed her post-graduation and fellowship from Narayan Nethralaya, Bangalore, and is currently practicing as a consultant at the Vision Eye Centers, New Delhi.
Thank you to Dr. Sneha and Dr. Aditi for having me again in the learner's basket this year. And in oculoplastics, actually covering a learner's basket is a bit complex because the surgeries are long and it's difficult to do it in 3 minutes. But I decided to rather go through a few scenarios which can sort of cover you and keep you safe in terms of oculoplastic surgeries, whether you're a general ophthalmologist practicing it or if you're a young oculoplastic surgeon. Yeah. So before you even go to a surgery, it's really important in plastics to take a picture. Otherwise, you have nothing to compare with, nothing to document. Even more importantly is to take consent, especially before taking photographs of the patient, and get important things done like phenylephrine tests to see if what surgery patients require. Do they need a fascinella servat surgery? Do they need a levator surgery? These things are really important. Even more importantly, do a cover test in any patient you're planning a ptosis surgery, especially children. So if a child has a squint, and if you don't correct the squint before doing the ptosis surgery, it could really be disastrous. When you get complex cases, don't be a novice and go ahead and do it. Ask somebody to help you. It's important to ask for help as well. Coming to certain intraoperative situations, in orbit surgery, if there's pupil dilation, it may be because you've injected with adrenaline, but if it is not, it's important to give steroids. Look for lid height intraoperatively. Look for things like tube breakage and slippage while you're operating. These things happen often. And post-operatively, it's important to manage hematomas really well. So get a good history, and even conducting, you may have motility restriction after orbital surgery, transient ptosis. So these are things which can be prevented with good dissection and performing the surgery well. And things like lower lid retraction, if they happen, you can treat it with 5-FU injections and steroids. This is something which happened to me actually. I didn't know it even happens. So this child underwent a really nice frontalis sling surgery with a good result. And over the days, he sort of developed a tube extrusion. So the tube had completely come out, but this was luckily managed well, where we could rebury the tube and it healed again well. So patients who come for aesthetic surgeries, they are very anxious, so it's important to psychologically counsel them well, and as well as to counsel them regarding post-operative care. Regarding scars, you should know how to manage them with injections, and I feel the best way to learn is by teaching. So thanks.
Thank you so much for that presentation, Rituja. So to discuss this case, we have none other than Professor Rajendra Prakash Maurya, sir. He is the in charge of the Ocular Oncology, Trauma and Oculoplasty Unit at the RIO Institute of Medical Sciences, BHU. Over to you, sir.
Thank you, Dr. Rituja, for giving an overview of things which could go wrong when one can start the oculoplasty practice. And I look that you have done a lot of difficult cases. Although the oculoplasty practice in youngers by beginners is again very difficult. And you concern and assess the psychology of the patient, that's very good, while practicing starting the aesthetic practice. Thank you.
Thank you, sir.
So all very nice presentations by all presenter speakers. I think everyone gets 100 out of 100 marks, no problem. Yes.
That is really good words of encouragement, sir. Do we have any questions from the audience? Okay. I think we are in time to conclude this session then.
We have 5 minutes more.
Can we have a closing comment from all of our panelists?
That's what it was the final shot. Everyone has presented very well, no problem. But we are very happy that beginners and all those are daring to do the challenging cases. That is very important. And nowadays, because of the CPA and all those practice pressures, many people like us seniors people are in a withdrawal mode or in a defensive mode. But again that you all have done all challenging cases. Hats off to you.
Thank you so much.
Thanks again to the beautiful moderators for the conference.
Thank you so
much.
That
needs a special
thanks.
Acknowledgement.
Thank you so much. Yeah, may I now request all the speakers, panel and moderators for a group photograph. We would also like to thank Dr. Partha Biswas sir for giving us this opportunity, and my beautiful, lovely, brilliant co-moderator Dr. Sneha, who's been a strong support with me since last year when we started this session. Thank you so much. Looking forward for next year.